Hello, doctors. How are you doing? How are you doing? Please let me know where you are joining me from right now. Let me know where you are joining me. Can you hear me, by the way? I want to make sure if you can hear me. If you can hear me, let me know. Can you hear me? Can you hear me? Just type yes, please. Let me know if you can hear me. Let me know if you can hear me. Let me know if you can hear me. I want to make sure you can hear me. Doctors, please, can you hear me? Can you hear me? Hello? Okay, good. Let's go. So today's class is going to be on approach to IUGR, okay? And I'm going to share my screen and then we will get into the game right away. I'm going to share my screen and we'll get into the game. Beautiful. Please, do you also see my screen? Do you see my screen? Do you see my screen? Please, do you see my screen? Do you see my screen? Okay. Okay. So, quick one. If you want to get in touch with me, my number is what is scrolling at the base. +1 306 891 5649. +1 306 891 5649. Okay. Please, if you want to get in touch with me, kindly text me by WhatsApp. I usually prefer WhatsApp. So please send a link to your friends, as many as possible. Dr. Denise Vinick says he's joining us from Calgary. Dr. Rockefeller is on. Dr. John Omwa is John from Ontario. Please send a link, YouTube link, to as many friends as possible. Number two, please, if you are here and you've not subscribed to the YouTube channel, kindly do so right away. Kindly do so right away, because we are on the way to 2,000, on the way to 2K, on the way to 2K. Wow, we have someone joining us from Tunisia. That's powerful. I'm very glad. Please share the link with as many friends as possible. Let's get into the game. Today we are learning approach to IUGR, and you need to remember that every MCCQE1 objective is very important, and that is why we at MedCognito are committed to make sure that we go through these very, very, very well. So the rationale is that intrauterine growth restriction is a pathological limitation of fetal growth. Now, the reason why you need to learn about this is that intrauterine growth restriction is an important risk factor for pre- and postnatal morbidity and mortality. Okay? You've got to appreciate that as well. It is also a risk factor for atypical child development. So look at the things the medical council is highlighting on. Pre- and postnatal morbidity and mortality, atypical child development, and adult health problems such as hypertension and diabetes. So when you are learning this particular topic right from the rationale, you've got to ask yourself, what are the pre- and postnatal morbidity and mortality issues associated with IUGR? Number two, what are the child development concerns which comes with IUGR? What are the adult health problems which comes with babies who are born with intrauterine growth restriction? Infants with IUGR must be distinguished from infants who are constitutionally small. So that's also another thing. In your exam, you've got to learn how to differentiate between a small for gestational age baby from an IUGR. Doctors, please, are we tracking together? If we are tracking, let me know that Dr. Brony, we are tracking, because the rationale is packed with so much. Okay, so let me know, Dr. Brony, we are tracking. We are tracking with you. We are tracking. Today, we're going to spend a good amount of time, to deal with this topic. So, just let me know that we are tracking, because it's very important. It's very, very important that we take our time to, get this right. We are tracking. Beautiful. So, I'm sharing this to those in our WhatsApp group as well, so that they can, get access right away. Let me go to the WhatsApp group and let them know we've started. Join. Okay. So, you know what? The causal conditions are, the list is not exhaustive, but we have maternal causes of IUGR, which is like the maternal nutritional state. We have fetal causes of IUGR like genetic syndrome, intrauterine infection. We also have, placental causes like maternal smoking. So we need to know the various, places that IUGR can get risk factors from. It can come from the mother, it can come from the baby itself, it can come from the placenta. All right? Okay, good. So, giving a pregnant patient with abnormal fetal growth or a newborn with low birth weight, the candidate will diagnose the cause, the severity, and complications, and will initiate an appropriate management plan. Particular attention should be paid to identification of modifiable risk factors for IUGR early in the pregnancy. Routine monitoring of fetal growth throughout pregnancy to identify the need for specialized obstetrical management, and careful evaluation of a neonate who is small for his gestational age to detect a possible case of IUGR and assess potential causal conditions. All right. So that is something we need to pay attention to so far as these key objectives are concerned. Now, what are the enabling objectives? Giving a pregnant patient with abnormal fetal growth or a newborn with low birth weight, the candidate will list and interpret critical clinical findings, including recognition of risk factors for IUGR. So, doctors, please write this down in your books. Write this down in your books. I need to know the risk factors for IUGR. The Medical Council of Canada wants me to know risk factors for IUGR. Okay, doctors, and as we go through this, please smash the like and subscribe button on our YouTube. Please. That's the least you can do for us. Click on the like and the subscribe button. Subscribe to our YouTube channel, okay? So that as soon as we go live, you can also get access right away. Please subscribe, and then let's build a channel together, okay? Please subscribe. Awesome. So, and routine monitoring of fetal growth through physical exam. And evaluation of a low birth weight infant to determine whether the case is one of IUGR or of a neonate who is constitutionally small for his gestational age. Paying particular attention to features on history and physical exam that are indicators of potential causal conditions. Okay, so I am moving to my next slide. List and interpret critical investigations, including indications for pregnancy investigations to assess fetal growth and well-being. For example, biophysical profile, Doppler, and indications for neonatal investigations for causal conditions of IUGR like karyotyping. Okay, and construct an effective initial management plan, including referral of the patient for a specialized obstetrical investigation and management, if indicated, and initiation of resuscitation of a distressed neonate as required. So that is like neonatal resuscitation. That is a whole lecture on its own. Okay. And referral for specialized pediatric care and developmental surveillance in the case of IUGR, and counseling and education of the patient regarding risk factors, management, and sequelae of IUGR as appropriate. So these are the things you want to pay attention to. So we're going to get into the introduction to IUGR. And as we do, I'm going to drop a question. But someone just asked the question here. Dr. Oriasoti says, and please, doctors, you can check on your YouTube screen or on your Facebook screen. It says, can intrauterine infection be said to be fetal? I think at best it should be fetal-maternal. Yeah. So intrauterine infection, well, it can be from the mother could pass an infection down to the baby. So I think it can be fetal-maternal, right? And I think your guess is as good as mine. So that's very good. Okay. So now let's do the first question. You have a 32-year-old prima gravida at 34 weeks gestation, presents for a routine prenatal visit. Her fundal height, remember she's 34 weeks, her fundal height measures 30 centimeters, prompting an ultrasound that reveals an estimated fetal weight in the 8th percentile for gestational age. Doppler studies show normal umbilical artery flow. What's the most likely implication of this finding? What's the most likely implication of this finding? A, the fetus is constitutionally small and not at risk increased risk. B, the fetus has increased risk of stillbirth if undetected. C, the fetus requires immediate delivery to prevent perinatal morbidity. D, the fetus is unaffected by maternal or placental factors. And E, the fetus has no long-term risks for neurodevelopmental delay. What is the most likely implication of this finding? So someone has given us one answer. Someone went for A. That's God's favor, Ihoma Bright. Some also went for B. Dr. Sabine also went for A. Dr. Yvette is going for B. Dr. Amna Umar is going for B. Dr. Jagdeep is also going for B. So it looks like some people are going for B, others are going for A. And doctors, while people are choosing whether they are going for A or B, don't forget to hit on a like and a subscribe button, and let's go. Okay, so many people are now going for B, others are still staying with A. Okay, and what is the correct answer? The correct answer is B. The correct answer is B. Fetal growth restriction is defined as failure to achieve genetic growth potential due to maternal, fetal, and placental issues. An estimated fetal weight less than 10 percentile suggests fetal growth restriction. In fact, in the notes, you realize that some authorities even talk about less than 5. But I think in general, if the estimated fetal weight is less than 10 percentile, it suggests fetal growth restriction. Okay. Undetected cases have an 8-fold increased stillbirth risk. So if you have a patient who has fetal growth restriction and that patient they don't diagnose it well so that the gynecologist can follow up or the obstetrician can follow up, what happens is that undetected fetal growth restriction has an 8 times increased stillbirth risk. Normal Doppler does not rule out fetal growth restriction. So if you get a patient who gets Doppler ultrasound done and the Doppler ultrasound is normal, it does not prove that there is no fetal growth restriction. Okay, so why is A wrong? A is wrong because constitutionally small implies that normal growth potential has been met, but fetal growth restriction indicates that there's a pathological process. So that is why A was wrong. Okay, doctors. So those who went for A, that is why A is wrong. Why is C wrong? Talking about immediately delivering the baby isn't indicated with normal Doppler. So if you have a patient with suspected fetal growth restriction and we are told that Doppler is normal, don't rush to deliver the baby right away. Okay, most of the time, if you have a patient with decreased growth velocity and you've diagnosed with increased intrauterine growth restriction, but you do the Doppler ultrasound and the Doppler ultrasound comes back normal, doctors, your next best step, so please write this down in your books, your next best step is for you to do surveillance. And I'm usually gladdened when, in the course of the class, you share a picture of where you are watching the class from and, the notes you are taking. It really gladdens my heart. I'll be very glad. The last time you guys did it was awesome. So just send a picture of where you are watching me from, your setup or something to my WhatsApp number +1 306 891 5649. It boosts my morale for me to know that what we are doing is really, really making an impact. Okay. And fetal growth restriction, by definition, involves maternal factors, fetal factors, and placental factors. Okay. And fetal growth restriction is linked to long-term risks like neurodevelopmental delay. So that is why A, C, D, and E are wrong. And the correct answer is B. Okay. Let's go to another question. You have a 35-year-old gravida 3 para 2 at 32 weeks gestation. He has an ultrasound revealing an estimated fetal weight less than 3/3 percentile. Doppler shows absent end diastolic flow in the umbilical artery. Fetal growth restriction is diagnosed and surveillance is initiated. What is the most significant long-term risk for this fetus if it survives the perinatal period? What is the most significant long-term risk for this fetus if it survives the perinatal period? Thank you, Dr. Florence, for sharing that picture. Awesome. That's great. A, increased risk of stillbirth. Remember, the question is, what is the most significant long-term risk for this fetus? A, increased risk of stillbirth. B, cardiovascular disease in adulthood. C, perinatal mortality. D, maternal hypertension. E, placental abruption. What's the correct answer? Oh, Dr. Florence, that's a wonderful setup. That's a wonderful, wonderful setup. Thank you very much for sharing that. Okay, that's a wonderful setup. So, what's the most significant long-term risk for this fetus? And the correct answer is B. Your guess is as good as mine. Remember that the text lists long-term morbidities of fetal growth restriction, including increased cardiovascular disease risk in adulthood. Okay, so stillbirth is a perinatal risk. It is not a long-term risk. Perinatal mortality is immediate. It is not a long-term risk, right? Maternal hypertension is a risk factor for fetal growth restriction. It is not a fetal outcome, right? And placental abruption isn't mentioned as a long-term risk. I think Dr. Jagdeep has also sent me something beautiful. People are really, really learning, and I love that. Great. Good. Okay. So let's go to the next question. Dr. Jagdeep, thank you for sharing that. You have a 30-year-old gravida 1/0 at 28 weeks gestation has a routine ultrasound showing an estimated fetal weight in the 12th percentile. Serial ultrasounds over 4 weeks show no growth progression. No maternal risk factors are identified. What is the most appropriate next step in management? A, immediate delivery to optimize outcome. B, initiate fetal surveillance for fetal growth restriction. C, reassure the patient that no intervention is needed. D, screen for maternal diabetes mellitus. And E, perform an amniocentesis for genetic testing. What's the correct answer? What's the correct answer? What's the correct answer? Ooh, the pictures are coming in. Thank you very much for sharing that. The pictures are coming in. I like that. I like that. I like that. I like that. So, what's the correct answer? What are you going to do? The correct answer is B. B. If the estimated fetal weight is less than 10 percentile or lack growth, it suggests fetal growth restriction. So remember that this one is in the 12th percentile, but has not been growing again. Okay, so fetal surveillance can be initiated upon diagnosing a reduced stillbirth risk. Because remember that the question also was talking about the fact that the ultrasound was good. So if ultrasound is normal, then just do surveillance. Delivery timing is optimized with surveillance, not immediate at 28 weeks without any severe findings. Okay, and no growth progression indicates fetal growth restriction, and it requires an action, not just reassurance. And the action is that we are going to do fetal surveillance. Okay, and why is D wrong? There are no maternal factors are noted, and diabetes isn't linked to fetal growth restriction. What is rather linked with fetal growth restriction is hypertension. Diabetes is usually linked with fetal macrosomia, big baby. Okay, all right. Why is E wrong? Genetic testing isn't indicated without specific fetal anomalies. So you will want to do genetic testing if there are any specific fetal anomalies in the baby. That is when you want to do genetic testing. Okay, next question. A 29-year-old gravida 2/1 at 38 weeks gestation delivers a newborn with a birth weight in the 4th percentile. Antenatal ultrasounds were normal, and the fetal growth restriction was not suspected. Okay, so they did not suspect fetal growth restriction, and I think I've already talked about that. The APGARs of the baby at birth were 8 and 9. What was the most significant undetected risk in this pregnancy? A, 8-fold increased risk of stillbirth. B, immediate neonatal hypoglycemia. C, maternal preeclampsia. D, placental infarction. And E, fetal chromosomal abnormality. 29-year-old, gravida 2, para 1, 38 weeks gestation, delivers a newborn with a birth weight in the 4th percentile. Antenatal ultrasounds were normal, and fetal growth restriction was not suspected. However, when the child was born, the ABGA scores were 8 and 9. What was the most significant undetected risk in this pregnancy? What's the most significant undetected risk in this pregnancy? The answer is A. Okay. Remember, we said that undetected. I had said it in a previous class or in a previous slide that if there's undetected fetal growth restriction, it increases stillbirth risk by 8-fold. Okay, it increases stillbirth risk by 8-fold. If there is any if there's fetal growth restriction, it increases stillbirth risk by 8-fold. And in this case, it wasn't identified antenatally. So if you have a baby whose fetal growth restriction is not detected, most of the time there's an 8-fold risk of stillbirth. Okay, and hypoglycemia isn't mentioned as a primary fetal growth restriction risk. Preeclampsia isn't indicated or linked to undetected. Remember, we are talking about undetected fetal growth restriction. And what we learn about undetected fetal growth restriction is that it has an 8-time or 8-fold risk of stillbirth, right? And placental infarction could contribute, but isn't specific as the key risk factor. And there is no evidence which suggests a chromosomal issue. Because most of the time, if there's a chromosomal issue, at times the baby may have some gross abnormality on ultrasound. Okay. So today I want you to note this. Many cases, and I quoted the source, okay, there. Why I'm focusing on like when growth restriction is not detected, what happens, okay? So many cases of fetal growth restriction are not detected antenatally. And the risk of stillbirth is increased 8-fold in undetected cases. And even when the most severe cases are detected, these cases are associated with high risk for adverse perinatal outcome. All right. So please, this is very important. I thought it wise that I should quote it and quote where I'm getting the source from. Okay. So now let's do a deep dive. Doctors, I have a question. Did the questions help? Did the initial questions we did help? Did the questions we did help? If it did, let me know. Did it help? Did it help? All right. Okay. Awesome. So now let's do a deep dive into fetal growth restriction. What is fetal growth restriction? Fetal growth restriction basically means that the baby doesn't grow to its potential set by its genes. Okay, that is all. So think about, a baby's growth plan. And the baby is supposed to grow to 100%, but then the baby grows to 60%. That is fetal growth restriction, basically, in simple terms. Okay, so think about the baby's growth plan getting stuck or slowed down. That is fetal growth restriction. Now, what are the causes of fetal intrauterine growth restriction? I want us to always look at it from 3 angles. 3. So please write these angles down. 3 angles. So Dr. Titi, Dr. Godfavor, Dr. Asia, Dr. Theodore Brown, Dr. Ada Glory, please write these 3 angles down. Why will there be fetal growth restriction? Number 1, it could be a problem with the mother's health. And some of the issues with the mother's health could be poor nutrition, high blood pressure, and it could be just pregnancy-induced hypertension, preeclampsia, Number 2, it could also be the baby's health itself. So think about the mother and think about the baby. So it could be genetic issues in the baby. Now, so we have the mother and the baby. And now think about the third thing. What links the mother to the baby? That is the placenta and the umbilical cord, right? So intrauterine growth restriction, when you're thinking about it, think about things which can affect the mother, think about things which can affect the baby, and think about things which can affect that which links the mother to the baby, which is the placenta. Because remember that placenta develops or delivers food and oxygen to the baby from the mother. Okay, so why is this baby small? It could be that there are some issues in the mother which is causing the baby to be small. Number two, it could also be that there are some issues with the baby itself. Or number three, it could be that there's some issue with the bridge which links the baby to the mother, which is the placenta and umbilical cord. So I want to look at it from this other angle. Think about intrauterine growth restriction in terms of building a house. Okay, and the house we are building is the baby, that's the fetus. Okay, and you know that usually when you are building a house, there must be a blueprint. Okay, there must be a blueprint. That is like the plan. So the plan is that the baby should grow to 100% potential, but then it could be that the genes of this baby, the blueprint was not drawn to 100%. It was just drawn to 60%. Number two, think about the mother as a supplier of all the things you need, the cement, the water, which has to come to the construction site, and all those things. And think about the placenta as a truck, which has to carry the building materials. So if there's a problem with any of these three, okay, the blueprint, or the mother who is a supplier, or the placenta, which is the truck to carry the materials, then there's a problem. Okay, so a problem with either the actual blueprint, the supplies for the building, or the truck carrying supplies to the building may mean there can be delays in the pace of the building. That is it. So you are a contractor, you are there. Hey, this building needs to get to 100%. But then, the supplier, they are on strike. That is the mother. Or the truck drivers say they are not going to carry anything to the site again. Doctors, please, does this example make sense? I want to know. Does it make sense? Thinking about fetal growth restriction as building a house. The house is the fetus. And there's the genes, which is the blueprint. There's the mother, which is the supplies. And then there's the placenta. Does this example make sense? If it makes sense, please let me know. Let me know. Let me know. Okay, Dr. Sabine says yes. That's good. So when I was thinking about it, I was like, you know what? How can I best let people understand this? Okay. All right. How common is IUGR? How common is IUGR? Statistics tells us that 1 in 10 pregnancies may suffer, some IUGR. So 1 in 10 pregnancies, IUGR. Think about that. Now, how do we detect IUGR? How do we detect IUGR? We use ultrasound to check the growth of the fetus. So how to check IUGR is by using ultrasound. Okay. But the truth is that IUGR is often missed. And when it is missed, there's an 8-time higher stillbirth risk if it is undetected. Okay? Because then you can't do any surveillance, you can't expect anything, and by the time the baby is born, 8 times risk of stillbirth if undetected. Now, why does IUGR matter? Remember that the objective was talking about it. Why does IUGR matter? Number one, there is increased risk of fetal morbidity. That's the short term. Number two, there's increased perinatal mortality. So these are the short-term concerns about why IUGR matters. Then what about the long-term concerns for the baby? The baby can have learning delays or learning disabilities. The baby can also have heart disease. Doctors, please write these down. This is very important because remember, it was in the objective. It was there. They stated it there. At times when you are just reading your textbook, you may not pay attention to these. It is during sessions like these that we can use to, break some of these concepts down. So we are looking at short-term concerns and long-term concerns. The long-term concerns can be learning delays, heart disease, diabetes, hyperlipidemia. So please learn this very, very well. Long-term concerns, learning delays, heart disease, diabetes, hyperlipidemia. Okay? Now, before we move on, I want to draw attention to something. We've been doing these med drills and it's been awesome, where I come in to meet the candidates. So come March 10th, I need you to mark your calendar. Okay? Come March 10th and March 26th, we're going to deal with emergency medicine. And the reason why I'm excited about emergency medicine is because if you look at the distribution of questions on the Medical Council of Canada's website, emergency medicine or acute medicine covers about 30 to 40% of cases. So I was doing the math and I realized that with the Medical Council of Canada changing the format of the exam, and now you're going to do 230 questions. If we are talking about 30 to 40% of the cases covering acute medicine, that means out of the 230 questions which you will meet in the morning and in the afternoon session, you are going to meet about 69 to 92 questions which cover acute stuff. Okay, so we've dedicated the month of March that despite all the Thursday and Sunday classes you'll be getting in MedCognito, we are going to do a deep dive into emergency medicine again. Because if out of every 10 questions, you're going to meet one emergency medicine question or one acute medicine question, then it is very important that we pay attention to that. We've done med drills in ethics in January, and we just finished med drills in psychiatry, and it was a bomb. So please, March 10th, March 26th, whether you are a MedCognito student or you are not a MedCognito student, you can enjoy the med drills. It is not meant for only MedCognito students alone. It is for everybody, okay? And if you want to get access to it, just send me a WhatsApp. Just send me a WhatsApp, +1 306 891 5649, and I'll be here to help you, okay? We'll give you access to it. So, this is some of the comments from some of the doctors. Thank you, Dr. Boni. Thank you, Dr. Boni. Thank you so much, Dr. Boni. It was an amazing session. Thank you so much, Dr. Boni, for the amazing session. I'm truly grateful to have such an inspiring teacher like you. Wishing you all the best, and may you be blessed abundantly. This is some of the feedback we got after we did the med drills. Now, let's get into assessment of fetal growth. So, doctors, I want to see you doing the med drills. So, med drills is, another top-up review of everything we do. And we've done that for ethics. We've done that for psychiatry, which a lot of candidates said was their weak point. And I can tell you, in psychiatry, we discuss more than 100 topics, right? And it's, bam, 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 question, answer, bam. And that's how we go around it. Okay, so Dr. Laurie says, emergency medicine as med drill is fire. Yes, of course. Emergency medicine is fire itself, and it is coming as med drill. So it's like fire plus kerosene. Boom. It's just going to explode. So please make sure March 10th and March 26th. All right, please book that time of 3 hours each with me, and we'll go through it. Okay. Now, let's review questions about assessment of fetal growth. Doctors, are we ready? Do you want to stretch out before we continue, or you want us to continue right away? Should we continue? If we should continue, let me know. Let me know. Because it looks like people are getting tired. If you want us to continue, just let me know. If you want us to continue, just let me know. Let me know. Okay. So, I have a question. A 28-year-old gravida 1 para 0 has an ultrasound at 10 weeks showing crown rump length consistent with last menstrual period. At 20 weeks, the biparietal diameter suggests 1 week discrepancy. What's the best basis for gestational age? In other words, this question is asking you, what is the best way to assess gestational age? A, last menstrual period alone. B, crown rump length at 10 weeks. C, biparietal diameter at 20 weeks. D, average of last menstrual period and biparietal diameter. And E, repeat ultrasound at 24 weeks. What's the best basis for assessing gestational age? What's the best basis for assessing gestational age? Last menstrual period alone, crown rump length at 10 weeks, biparietal diameter at 20 weeks, average of last menstrual period and biparietal diameter, and repeat ultrasound at 24 4 weeks. What's the correct answer? Doctors, as we are answering, please click on the like and subscribe button on YouTube, please, because the more people engage with it, the more the algorithm will also let other people who have never even seen it, get interested in it. So please just help us, okay? So some are going with A, which is last menstrual period alone. Dr. Titi Ogunlade goes with B, crown ramp length at 10 weeks. What's the best basis for gestational age? The correct answer is B. B. Crown ramp length in first trimester is ideal for dating a pregnancy. Crown ramp length. Remember, if we are using last menstrual period, it still needs ultrasound to confirm. It still needs ultrasound on top. And biparietal diameter before 22 weeks is okay, but it is less accurate than crown ramp length. Okay, so crown ramp length is top. Crown ramp length is top. If you want to assess gestational age, the most accurate measurement you want to use is crown ramp length. And the crown ramp length is done in the first trimester. Okay, next question. A 28-year-old prima gravida at 32 weeks presents for routine antenatal care. An ultrasound estimates fetal weight at the 8th percentile for gestational age. The pregnancy has been otherwise uncomplicated. Which of the following is the most appropriate next step? A, immediate induction of labor. Remember, this baby is 32 weeks, right? B, repeat ultrasound in 2 weeks. C, Doppler ultrasound of the umbilical artery. D, administer corticosteroids for fetal lung maturation. And E, perform amniocentesis for genetic testing. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? What's your correct answer? Looks like everybody is quiet now. So some people are going with C, Doppler ultrasound of the umbilical artery. What other answers will you go for? Dr. Abiranthe went for B, repeat ultrasound in 2 weeks. So it looks, and some are even going for D, administer corticosteroids for fetal lung maturation. So it looks like we have B, C, D. B, C, D. B, C, D. B, C is British Columbia. So people are going with British Columbia and they are adding Detroit, right? B, C, D. And what's the correct answer? The correct answer is C. C for Calgary. C for Calgary. That is Doppler ultrasound of the umbilical artery. And the explanation is this. The fetus is in the low percentile for growth, which raises a suspicion for fetal growth restriction. Now, remember that we're talking about the areas where fetal growth restriction can be coming from. It can be a maternal issue, it can be a fetal issue, but it can also be a placental and umbilical cord issue. So when you've seen something like this, that a baby has intrauterine growth restrictions, okay, Doppler ultrasound of the umbilical artery helps to assess placental insufficiency, which is a key cause of fetal growth restriction. And I'll be making a point at the end of the class to nail this down. Okay, so Dr. Riasoti says Calgarians have won it. Yes, Calgarians have it. Beautiful. So immediate delivery is not indicated unless there are signs of distress in the fetus. And routine follow-up alone is insufficient. And giving steroids are given for preterm labor, not isolated growth concerns. And amniocentesis is unnecessary without additional risk factors. Remember that if you are doing amniocentesis, then you're thinking about maybe this baby has some chromosomal concerns, right? And that is a very, very invasive test. So you want to be very careful. So you want to rather do your Doppler ultrasound of the umbilical artery. Next question. You have a 35-year-old woman at 20 weeks gestation undergoes fetal anatomy scan. The ultrasound team calculates the estimated fetal weight using the Handlock formula, which incorporates which of the following measurements? A, crown ramp length. B, biparietal diameter, head circumference, abdominal circumference, femur length. C, umbilical artery Doppler waveform. D, maternal weight and height. And E, fetal kidney length. What's the correct answer? So the correct answer is B. So if you want to do estimated fetal weight, you need to depend on the biparietal diameter, the head circumference, abdominal circumference, and the femur length. Okay. So when you want to do good estimated fetal weight assessment, please write this down in your notebook. The 4 things I'm going to use to assess estimated fetal weight are: number 1, biparietal diameter; number 2, head circumference; number 3, abdominal circumference; and number 4, femur length. These are the 4 things I'm going to use to assess estimated fetal weight. Please write them down in your book. Write them down in your book. Biparietal diameter, head circumference, abdominal circumference, and femur length. These are the 4 things I'm going to use. So if you are sleeping and Dr. Bruni wakes you up, like the way I wake up the MedCognito students in the WhatsApp group, hey, doctors, please wake up and study. And I ask you, doctor, what are the 4 components, or what are the 4 things I can use to do an assessment of fetal weight? Remember, biparietal diameter, head circumference, abdominal circumference, femur length. Doctors, let's move on. Dr. Cyril, please, it's not D, it's B. Okay? All right. Next question. A 29-year-old woman presents at 36 weeks gestation. Ultrasound estimates fetal weight at the 92nd percentile. Which of the following factors is most strongly associated with this finding? A, short maternal stature. B, fetal sex, which is male. C, maternal pre-gestational diabetes. D, use of assisted reproductive technology. And E, nulliparity. Bam, 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 bam. So, doctors, what's the correct answer? A? Is it B? Is it C? Is it D or E? Remember that this time the baby is in the 92nd percentile. 92nd. Dr. Yvette, don't break my heart. Dr. Yvette, don't break my heart. Don't think that because we are doing intrauterine growth restriction, so that is all we are thinking about now. Okay? Is it A, short maternal stature? Is it B, fetal sex? Is it maternal pre-gestational diabetes? Is it use of assisted reproductive technology, or nulliparity? What's the correct answer? What's the correct answer? It looks like the correct answer is maternal pre-gestational diabetes. This baby is in the 92nd percentile. Big, right? Maternal diabetes increases fetal glucose availability, promoting macrosomia, large fetal size. Okay? Remember that if a mother has a short stature, that is rather associated with smaller babies. That is constitutionally small babies because the mother is constitutionally small, right? And males are slightly heavier at birth, but are not a primary cause of excessive growth. When you're thinking about excessive growth, think about maternal pre-gestational diabetes, okay? And assisted reproductive techniques affect early gestational age assessment, but not directly with macrosomia. All right. And nulliparity does not significantly influence fetal size. Beautiful. Dr. Yvette, thank you very much. She says, thanks for the explanation. Awesome. 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 Next question. A 32-year-old woman at 28 weeks gestation undergoes fetal growth assessment. The sonographic estimated fetal weight is at the 15th percentile, and the umbilical artery Doppler shows normal blood flow. What's the most appropriate management? A, immediate delivery. B, weekly biophysical profile. C, continue routine prenatal care. D, repeat ultrasound in 4 weeks. And E, administer corticosteroids. What's the correct answer, doctors? What's the correct answer? What's the correct answer? And doctors, don't forget, you can get in touch with me at +1 306 891 5649. +1 306 891 5649. Okay. Usually I prefer WhatsApp message so that I can respond to anyone from across the world. If you send a text message and you're outside Canada, it becomes difficult. But WhatsApp, I can do that. Oh, somebody is saying, what's the difference between 92nd and the 9th percentile? 92nd percentile is a big, like 92%, right? And 9th percentile is really small, like a very little baby. So 92nd percentile is a very big baby. Usually you want the babies, like everything, you want it to be around the 50th percentile. So somebody is scoring 92nd percentile. That is huge. 9th percentile is like really small, right? So Dr. Michael Israel, I hope I've helped you. Okay, so what's the correct answer? I see some people are going for B, weekly biophysical profile. Some are going for D, repeat ultrasound in 4 weeks. And some are also going for C. What's the correct answer? What's the correct answer? The correct answer is C. Remember that we said that fetal growth restriction is when the estimated fetal weight is less than the 10th percentile. In fact, some literature even talks about less than the 5th percentile, but usually I will go the 10th percentile. So if you have a baby and you measure the percentile and it is 15th percentile, that is within normal limits. So the normal percentile is anything above 10th percentile in terms of fetal growth restriction, right? If the baby is above the 10th percentile in terms of fetal growth restriction, you are happy. Okay. For large babies, I have to read about it and let you know. But if it comes to fetal growth restriction, any baby who is above the 10th percentile is okay. And so this baby's percentile is 15%, 15th percentile. And so that is okay. And so you don't need to do anything wild. Just continue your routine prenatal care and you're good. Okay? Immediate delivery is not warranted in this baby. And a biophysical profile is used for fetal distress. All right? And you will give steroids only for preterm delivery concerns. So please remember, if the baby's percentile is less than 10th percentile, that is when you start thinking about growth restriction. Okay? So doctors, remember, something big is coming. And starting in March, we're going to start our mock exams. It's going to be weekly. So if you want to participate in the mock exams as well, that is what our candidates use to ace the exam, because it gives them a feel of the exam. We put you under exam conditions, right? And you sit down, there's an invigilator, it puts you under exam pressure. You have other candidates in the room with you writing the exam. So it gives you, this exam room vibe, right? So please, come March, we are starting, because the exam first batch goes in April. So we're going to start back to back mock exams. Okay? So come March, we are starting. So please, kindly note it down. If you have any questions about that, reach out and I'll help you with it. So let's do a deep dive into assessment of fetal growth. Assessment of fetal growth. Let's do a deep dive. Now, the best method the best method to predict fetal age is when you use the crown rump length in the first trimester. Okay? If you want to assess fetal weight beyond the first trimester, you need to do your fetal biometry, and that's what I talked about. The 4 components, doctors, please. The 4 components. Biparietal diameter, head circumference, fetal length, and abdominal circumference. Okay, and you want to make sure that the goal is to ensure the estimated fetal age matches expected growth standards. The goal is to ensure the estimated fetal age matches expected growth standards. Now, how do you measure fetal size and estimated fetal weight? Ultrasound is the gold standard for measuring fetal size. And the accuracy of estimated fetal weight is not perfect, and with a margin of error of over 14%, leading to potential over or under diagnosis for growth abnormalities. So even with ultrasound, there can be an error of about 14%. Now, Dr. Atun Bright is asking me this question. Please, Dr. Bruni, is the fetal growth not expected to correlate to the gestational age? Yes. So it should correlate to the gestational age with a plus or minus 2. Okay. So, for example, if I measure the patient's abdomen and the abdomen measures 24 centimeters, usually I can estimate that the fetal the fetal age is about, if I say 24 centimeters, then the fetal age should be between 22 to 26, plus or minus 2. Okay, 20 to 26. Okay. So let's master some definitions as well, because the Medical Council wants us to also know that. Let's master some definitions as well. And we're going to go with some questions to do this. A 30-year-old woman at 34 weeks gestation undergoes a routine ultrasound, which shows an estimated fetal weight at the 5th percentile for gestational age. Doppler ultrasound of the umbilical artery is normal. The mother has no history of hypertension or diabetes. What's the most appropriate diagnosis? A, early onset fetal growth restriction. B, late onset fetal growth restriction. C, severe fetal growth restriction. D, small for gestational age. And E, normal fetal growth. What's the correct answer? Is it A, is it B, is it C, or is it D? So I'm seeing all the answers. I'm seeing A, I'm seeing B, I'm seeing C, I'm seeing D. I think the only one I've not seen is E. The only one I've not seen is E. So basically the question is asking you that you do an ultrasound, you do the crown rump length, or no, even you do the abdominal circumference, you do the femur length, you do, the head circumference, and you do everything, and you get a baby who is in the 5th percentile for gestational age. How will you classify that baby? Is it early onset fetal growth restriction? Is it late onset fetal growth restriction? Is it severe fetal growth restriction? Or is it small for gestational age or normal fetal growth? And the answer is late onset fetal growth restriction. Let's go through the definitions. Remember that we said that fetal growth restriction is when the estimated fetal weight is less than 10%, the 10th percentile. Now, since this fetus was diagnosed above 32 weeks, it is classified as late onset fetal growth restriction. Okay? Doppler being normal suggests low risk of complications, and severe fetal growth restriction requires the estimated fetal weight to be less than 3rd percentile. So for you to say that the baby has severe fetal growth restriction, the estimated fetal weight should be less than the 3rd percentile. Less than the 3rd percentile. Now, so the learning point is this. Please write this down. The learning point is this. If you have a fetus and the fetus was growing well, and maybe around 36 weeks, you realize that the fetus's weight has now dropped below the 10th percentile. That is late onset fetal growth restriction. So when fetal growth restriction sets in after 32 weeks or at 32 weeks or above, that is what we call late onset fetal growth restriction. Please, doctors, is that okay? I want to know. Is that okay? Is that okay? Is that okay? Is that okay? If fetal growth restriction starts at or anytime above 32 weeks, that is what we call late onset fetal growth restriction. So, Dr. Risati, don't assume things in the question, right? The question basically says 34 weeks gestation, undergoes routine ultrasound, which shows an estimated fetal weight at 5th percentile. Don't forget that we do one ultrasound at 20 weeks. And it looks like they didn't really comment about that. So assume that the 20-week ultrasound was normal. Now they did another one at 34 weeks, and it looks like it was abnormal. And so we've picked up this fetal growth restriction after 32 weeks. That is why we say it is late onset fetal growth restriction. Now, remember that Medical Council also wanted us to learn about the difference between small for gestational age and fetal growth restriction. Small for gestational age can only be diagnosed after birth. Let me say that again. You need the mother to have delivered the baby before you can say that this baby is small for gestational age. But fetal growth restriction can be diagnosed even with the baby in the mother's womb. Let me say that again. Small for gestational age is only diagnosed after birth, not in utero. Fetal growth restriction is diagnosed in utero. Next question. We have a 28-year-old woman at 30 weeks gestation undergoes an ultrasound, and the estimated fetal weight is at the second percentile. Umbilical artery Doppler shows reversed end diastolic flow. Which of the following is the most likely diagnosis? A, mild fetal growth restriction. B, severe early onset fetal growth restriction. C, small for gestational age. D, late onset fetal growth restriction. And E, macrosomia. 30 weeks gestation, baby is at second percentile. Baby is at second percentile. What's the correct answer? Baby is at second percentile. What's the correct answer? So the correct answer is severe early onset fetal growth restriction. Remember, we said that late onset fetal growth restriction is when it happens at or after 32 weeks. So any fetal growth restriction which happens before 32 weeks is early onset fetal growth restriction. Okay? And the estimated fetal weight less than the third percentile shows that there's severe fetal growth restriction. So you have severe fetal growth restriction plus it is happening before 32 weeks. So that is severe early onset fetal growth restriction. Okay? And reversed end diastolic blood flow is a marker of severe placental insufficiency. Please write this down. Doctors, please write this down. Write this down. If you see a patient and you are told that this patient has reversed end diastolic flow, it is a marker of severe placental insufficiency. Severe placental insufficiency. You have a patient, okay, and you are told that there's reversed end diastolic flow. Please write it in your book, highlight it, make a star around it, send me a picture of what you've done, put a sticker around it. Reversed end diastolic flow is a marker of severe placental insufficiency. Next question. You have a fetus at 36 weeks gestation, is diagnosed with fetal growth restriction based on estimated fetal weight at the 7th percentile. What's the most appropriate next step in the management? A, deliver immediately by cesarean section. B, repeat ultrasound in 2 weeks. C, conduct umbilical artery Doppler ultrasound. D, administer corticosteroids. And E, no further action is needed. Babies at 7th percentile, gestational age of 36 weeks. What's the most appropriate next step in the management? The answer is C, umbilical artery Doppler ultrasound. Remember, we've talked about this before, right? Since FGR is suspected, Doppler ultrasound helps to assess placental function. Immediate delivery is not indicated unless there's fetal distress. Repeating ultrasound in 2 weeks is too late for ongoing monitoring, and steroids, you usually give it in preterm labor. And no action is inappropriate since fetal growth restriction requires monitoring, and you want to do your umbilical artery Doppler ultrasound. Next one. Which of the following factors is most strongly associated with early onset fetal growth restriction? Early onset fetal growth restriction. A, maternal obesity. B, maternal hypertension and placental dysfunction. C, maternal multiparity. D, maternal anemia. E, maternal fetal sex. Male fetal sex. Male fetal sex. Which of the following factors is most strongly associated with early onset fetal growth restriction? A, maternal obesity. B, maternal hypertension and placental dysfunction. C, maternal multiparity. D, maternal anemia. And E, male fetal sex. So the correct answer is maternal hypertension, which is B. Maternal hypertension and placental dysfunction. Early onset fetal growth restriction, which is less than 32 weeks, is commonly caused by placental insufficiency, okay, which is associated with hypertension, preeclampsia, and vascular disease. So that is the learning point here. Usually, if you see a patient with early onset fetal growth restriction, it is caused by placental insufficiency, which is associated with hypertension, preeclampsia, and vascular disease. Next question. A newborn is classified as small for gestational age at birth. Which of the following statements is correct regarding the relationship between small for gestational age and fetal growth restriction? Remember, the MCC talked about that in the objective, right? So A, all fetuses diagnosed with fetal growth restriction will be small for gestational age at birth. B, small for gestational age infants always have underlying pathology. C, small for gestational age is defined based on birth weight, while fetal growth restriction is diagnosed in utero. D, small for gestational age and fetal growth restriction are interchangeable terms. E, small for gestational age infants have higher rates of placental insufficiency than fetal growth restriction fetuses. What's the correct answer? People are writing the answers. People are writing the answers. C, 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 C. Others are saying C, C. So we learned the small for gestational age is defined based on birth weight, while fetal growth restriction is defined or diagnosed in utero. Now, the explanation is this. Small for gestational age is a newborn birth weight less than the 10th percentile, while fetal growth restriction is a prenatal diagnosis, which is done while the baby is in the uterus, okay? Now, not all fetal growth restriction babies are born small for gestational age. Why? Why do we say that? Because it could be that, at 32 weeks, you did the ultrasound, the baby was at the 7th percentile, but by 40 weeks, by the time the baby is born, the baby is now at 20th percentile. So not all fetal growth restricted babies are born small for gestational age. And the flip side is also true. Not all small for gestational age babies have fetal growth restriction during pregnancy. What do I mean by this? For example, if the mother herself is constitutionally small, definitely the mother will give birth to a constitutionally small baby. But that does not mean that that baby has fetal growth restriction. Hello, doctors. And some small for gestational age infants are constitutionally small. Like they are healthy, but they are small. Why? Because their mother is small. While others may have growth restriction. So don't confuse the two. Small for gestational age is diagnosed when the baby is born. Fetal growth restriction is diagnosed in the uterus. Okay? Now, let's do a deep dive into the definitions used in intrauterine growth restriction. Fetal growth restriction is defined as estimated fetal weight or abdominal circumference less than the 10th percentile, okay, for gestational age due to a pathologic cause like placental insufficiency and genetic abnormalities. Different guidelines may also diagnose fetal growth restriction as abdominal circumference less than 5th percentile, but usually I prefer the 10th percentile one. So please go for the 10th percentile one, okay? Use the 10th percentile one. Now, when we say severe fetal growth restriction, what do we mean? We've already discussed this, but this is just to brush up on things. It is defined as the estimated fetal weight or abdominal circumference less than the 10th percentile. Severe fetal growth restriction, less than the 10th percentile. And it has high risk of stillbirth, perinatal morbidity, and mortality. And umbilical artery Doppler abnormalities, for example, absent or reversed blood flow, suggests severe placental dysfunction. I've already said this in the past, right? So in your board exam, whether it's for the USMLE, the AMC, PLAB, MCCQE1, if you note that a patient has umbilical artery abnormalities, for example, absent or reversed blood flow in the umbilical artery, think about severe placental dysfunction. All right? Okay. What about early onset growth restriction? That is if the growth restriction is diagnosed before 32 weeks of gestation. It shows more severe It is often linked with placental insufficiency, preeclampsia, and early fetal deterioration. So if I should ask you, you have a baby whose growth restriction was demonstrated at 28 weeks, and you have a baby who was doing well and the growth restriction was diagnosed at, say, 36 weeks, who has an increased risk of early fetal deterioration? It is the one who was diagnosed way early. Okay. Now, early onset fetal growth restriction, there's a high risk of preterm birth and complications. Now, what about late onset fetal growth restriction? Late onset fetal growth restriction. It is diagnosed at more than or equal to 32 weeks gestation. And late onset fetal growth restriction is more common than early onset fetal growth restriction. And it has lower risk of perinatal morbidity, but may lead to long-term neurodevelopmental issues. So remember, early onset fetal growth restriction, late onset fetal growth restriction. Early onset is diagnosed before 32 weeks. Late onset is diagnosed at 32 weeks or more. Which one is more common? Late onset. Which one has a higher risk of perinatal morbidity? Early onset. But which one has, a higher risk of, or like which one is also associated with long-term neurodevelopmental issues? It can be the late onset. The early onset can also do that. Okay. All right. So now let's talk about small for gestational age, because the medical council said we should be able to differentiate between the two, right? Small for gestational age, remember, you diagnose it after the baby is born. All right. So it is defined as a newborn birth weight less than the 10th percentile. It is not always due to fetal growth restriction, and some babies are naturally small, but they are healthy. All right. Okay, good. So note, I want you to note this. Not all fetal growth restricted babies are born small for gestational age. And not all small for gestational age babies had fetal growth restriction during pregnancy. I'm just trying to hit on this, so that we can, get a good thing home. So I want to summarize everything. And if you want to summarize, I have this acronym for you. FGR, that's fetal growth restriction, seals the outcome. Okay? So fetal growth restriction, what do we mean? It's when the estimated fetal weight or abdominal circumference is less than 10 percentile. Forget about the 5th percentile one. Go with the 10 percentile one. Gestational age matters. If it occurs before 32 weeks, usually it is called early onset fetal growth restriction. If it occurs at 32 weeks or more, it is called late onset fetal growth restriction. Usually, the complications of early onset fetal growth restrictions are more severe than the complications of late onset fetal growth restriction. If you see that there is reversed end diastolic flow on Doppler ultrasound, that is severe. Okay? And severe FGR, that is less than 10 percentile, there's a high risk. Early onset fetal growth restriction usually comes with placental insufficiency. Late onset fetal growth restriction, there's a risk of neurodevelopmental delays. Late onset fetal growth restriction, there's less risk, but still you have to monitor the patient. And again, not all small for gestational age babies always show that there's fetal growth restriction and vice versa. Okay, so now let's look at the risk factors for fetal growth restriction. Doctors, please, so far, has a class made sense to you? I want to know, has a class made sense to you so far? I really, really need your feedback. Has it made sense to you? Has it made sense? Has a class made sense to you today? Has it made sense? Has it made sense? Has the class made sense so far? Beautiful. Beautiful. Someone says crystal clear. Boom. Someone says absolutely makes sense. Makes sense. Beautiful, beautiful, beautiful. So much sense. Finger red number 1. Well, I don't know what that means, but wonderful. Okay, made sense. So that's good. Okay. So we have to also know the risk factors for fetal growth restriction. So doctors, as you are typing made sense, please hit on the like and the subscribe button. Please, please. We need 4 more subscribers to hit 1,970 subscribers. Please click on the like and the subscribe button on YouTube. Do that right away. Please do that. In fact, move us to 2,000 subscribers right now. Click on the like and subscribe button right now on YouTube, and let's move on. So let's know the risk factors for fetal growth restriction. So, question: you have a 29-year-old woman with chronic hypertension at 28 weeks gestation. An ultrasound shows estimated fetal weight at the 5th percentile with abnormal umbilical artery Doppler findings. What's the most likely underlying cause of this condition? A, fetal chromosomal abnormality. B, maternal vascular disease. C, placental infection. D, malnutrition. And E, maternal age. What's the correct answer? Dr. Riasoti is saying something here. He says it's very relevant, especially as it highlights the common mistakes and misconceptions that most doctors may have. Thank you, Dr. Bruni. Yeah. Thank you, Doc. I'm happy we're doing something good. So, 28-week gestation, ultrasound shows estimated fetal weight at the 5th percentile with abnormal umbilical artery Doppler findings. What's the most likely underlying cause of this condition? And the answer is B, maternal vascular disease. Remember that chronic hypertension is a major risk factor for placental insufficiency, and it leads to fetal growth restriction. Okay, and chromosomal abnormalities are more common in early onset fetal growth restriction, but would require genetic testing to confirm it. Placental infections can cause fetal growth restriction, but less common than vascular disease. Okay, and malnutrition can contribute to fetal growth restriction, but is less common. And maternal age alone is not a primary cause of fetal growth restriction. Next question. You have a 35-year-old woman at 30 weeks gestation, has an estimated fetal weight at the 4th percentile. She denies any history of hypertension or diabetes, but has been long-term smoker, which are the following best explains the pathophysiology behind the fetus's growth restriction. A, decreased placental blood flow due to vasoconstriction. B, increased maternal insulin resistance. C, increased fetal oxygenation. D, decreased risk of neonatal complications. And E, increased nutrient transport to the fetus. What's the correct answer? Is it A, is it B, is it C, is it D, or is it E? Doctors, please still send me, where you are watching this class from. Please, it really, really helps me. Send me a picture on +1 306 891 5649. Okay. So what's the correct answer? Smoking. What does smoking do? Smoking causes decreased placental blood flow. So the answer is A. Why? Because tobacco causes vasoconstriction and it reduces placental blood flow and it leads to chronic hypoxia. Okay? It leads to chronic hypoxia. So that's what tobacco does. Remember that when someone takes tobacco, it decreases fetal oxygenation. It does not increase it. Okay. Next question. Which of the following conditions is most strongly associated with early onset fetal growth restriction? A, maternal cocaine use. B, velamentous cord insertion. C, cytomegalovirus infection. D, placental insufficiency. And E, fetal trisomy 18. Early onset, most strongly. Remember the words, most strongly. So that means that you may have answers there which are also associated with early onset fetal growth restriction. But which of them is most strongly associated? Most strongly. The answer is fetal trisomy 18. Remember that another thing you want to pay attention to is that early onset fetal growth restriction is often caused by genetic abnormalities. Okay? That is something you want to note. Now, why are the rest of the answers wrong? Cocaine use is more commonly associated with late onset fetal growth restriction. Okay, cocaine use is associated with late onset fetal growth restriction. Velamentous cord insertion can restrict blood flow, but is not the most common cause of early fetal growth restriction. Okay, and cytomegalovirus can cause fetal growth restriction, but is only responsible for just 5 to 10% of cases, so that's a little low. And placental insufficiency is a key contributor to fetal growth restriction, but is more commonly associated with maternal conditions like hypertension. So if you are looking at, fetal growth restriction, very early onset, think about some things which are going on in the baby, genetic issues like trisomy 18. Okay, next question. A 24-year-old woman at 32 weeks gestation undergoes an ultrasound that reveals estimated fetal weight at 33rd percentile. Doppler studies show absent end diastolic flow in the umbilical artery. Which of the following risk factors is most strongly associated with this condition? A, gestational diabetes. B, fetal aneuploidy. C, maternal preeclampsia. D, velamentous cord insertion. And E, maternal obesity. Absent end diastolic flow in the umbilical artery. And the correct answer is maternal preeclampsia. Okay, so that is C. C. Severe fetal growth restriction with abnormal Doppler findings suggests placental insufficiency, most commonly seen in preeclampsia. And gestational diabetes is more associated with macrosomia, and fetal aneuploidy can cause fetal growth restriction, but placental dysfunction is a more immediate concern. Okay, and cord abnormalities can be a factor, but they are not the primary cause of placental insufficiency. So think about maternal preeclampsia. Okay, so let's look at the deep dive into the risk factors for IUGR. Remember that I was telling you that IUGR, if you're thinking about IUGR, think about the baby as a building, think about the genes as the blueprint, think about the mother as a supply, and think about the placenta as a truck, which is carrying the building materials. Okay, and so if you have a problem with any of them, there can be a problem with the house in general. So fetal genetic abnormalities that cause IUGR: aneuploidy, including even triploidy, single gene pathogenic variants, partial deletions or duplications, and at least 50% of fetuses with trisomy 13 or trisomy 18 have fetal growth restriction. Okay, now while we are talking about fetal growth restriction, we also have to learn about symmetric fetal growth restriction and asymmetric fetal growth restriction. In symmetric fetal growth restriction, both the head, symmetry, both the head and the abdomen are small. Symmetric, both the head and the abdomen are small, and usually prior to 20 weeks of gestation suggests aneuploidy as a cause. Okay, that's why that question, it was trisomy 18 or 13, which was the correct answer. And the most commonly known cause of symmetric FGR prior to 20 weeks is trisomy 18. Then, if you have a baby with asymmetric FGR, that means that the head is usually normal, but the abdomen is small. That means that usually, or the head is not small, but the abdomen is small. Okay. Meanwhile, symmetrical, the abdomen is small, the head is small. So that one, you're thinking about conditions like Russell-Silver syndrome, Temple syndrome, Smith-Lemli-Opitz syndrome, Prader-Willi syndrome. Okay. These ones, just learn them. Causes of symmetric trisomy 18 is the most common. Asymmetric, consider medical conditions like Russell-Silver, Temple syndrome, Smith-Lemli-Opitz, and Prader-Willi. Okay. Fetal infections that can lead to intrauterine growth restriction. You have to know them. Cytomegalovirus and toxoplasmosis. Please write them down. Cytomegalovirus and toxoplasmosis are the most common infectious etiologies of fetal growth restriction in high-income countries. High-income countries. And malaria is also a common infectious cause in endemic areas. So you take like places like West Africa, right? But in high-income countries, cytomegalovirus and toxoplasmosis are the most common infectious etiologies. Okay, multiple gestation is also a risk factor. And the reason is because, lower weights of fetuses for multiple gestation is thought to be due to an inability of the uteroplacental environment to meet the nutritional needs of the multiple fetuses. So take all factors being equal, the same patient carrying just one baby and carrying 3 babies and has to supply like both of them or both situations with the same amount of food from the mother. The one with a single baby can serve the single baby better than the one with the triplets, right? And so that can be a situation. Now, we also know that multiple gestation has complications like preeclampsia and twin-to-twin transfusion syndrome, right? And placental and umbilical anomalies potentially associated with underperfusion are also more common in multiple gestation. So like filamentous cord insertion. So multiple gestation can also lead to intrauterine growth restriction. And then ischemic placental disease. Now, this is what I was talking about, placental insufficiency. Write this down. Put a star around it. Put a smiley face around it. Remember that primary placental insufficiency is the most common cause of fetal growth restriction. Primary placental growth. And that is why I've written there, common things are common. So how can ischemic placental disease manifest in pregnancy? It can manifest as preeclampsia. It can manifest as placental abruption. It can even manifest as stillbirth. And in most cases, it is often recurrent. So please write it down. Primary placental insufficiency is the most common cause of fetal growth restriction. What about umbilical cord and placental abnormalities? Single umbilical artery is one of them. Filamentous umbilical cord insertion is another one of them. Marginal cord insertion is another one. Bilobe placenta is another risk factor. Circumvallate placenta and placental hemangioma. These are all risk factors for IUGR. These are umbilical cord and placental abnormalities. Okay. Now, what about abnormal maternal biochemical markers for Down syndrome? So you have a mother, you do Down syndrome screening, and they have low pregnancy associated plasma protein. They also have low beta HCG, but they have high alpha fetoprotein. Please, they have an increased risk of IUGR. And these are the biochemical markers for Down syndrome. Doctors, I'm pouring a lot of information in the risk factors because the risk factors is big for your board exam. Big. The medical council wants you to know that. They noted it in their in the objective, right? That's why I'm taking my time to go through it. So, what are the markers of Down syndrome? Abnormal biochemical markers: low pregnancy associated placental plasma protein A, B, low beta HCG, C, high alpha fetoprotein level. Okay, what about maternal genetic factors? Mothers who were growth restricted at birth also have a twofold increase in risk of fetal growth restriction in their offspring. So if the mother herself had fetal growth restriction, then the mother has an increased risk of passing that on or having children with fetal growth restriction as well. And mothers who give birth to a fetal growth restricted newborn are also at high risk of recurrence. Okay? And so please note it. If the mother herself had fetal growth restriction, chances are that mother can also give birth to children with fetal growth restriction. And mothers who give birth to a fetal growth restricted newborn are at high risk of recurrence. Okay. Now, what about the maternal, medical, and obstetric conditions which can lead to fetal growth restriction? We have preeclampsia. This one, write it down quickly. Preeclampsia, placental abruption, chronic hypertension, chronic kidney disease, okay, pregestational diabetes mellitus, SLE, antiphospholipid syndrome, cyanotic heart disease. So the mother has cyanotic heart disease as well. Chronic pulmonary disease, severe chronic anemia, Okay, sickle cell disease, uterine malformations. If the mother is using drugs like alcohol, cigarettes, heroin, cocaine, pre-pregnancy radiation therapy to the pelvis, heavy first trimester antepartum bleeding, previous small for gestational age newborn, and previous stillbirth, unless placental insufficiency was excluded. These are all maternal obstetric and conditions that can lead to fetal growth restriction. Okay, now what about teratogens? Medications and teratogens and environmental factors that can lead to fetal growth restriction. Warfarin, anti-seizure medications like valproic acid, okay, anti-neoplastic agents. So if the mother is going through, some form of cancer treatment as well, folic acid antagonists, medications which antagonize folic acid, maternal alcohol use, maternal tobacco use, maternal marijuana use, air pollution in the environment of the mother, and therapeutic radiation, okay, can cause permanent restriction of growth. And other risk factors I'm taking my time on the risk factors because it's very, very important. Other risk factors for IUGR in the mother can be assisted reproductive technologies, low pre-pregnancy weight. So before the mother was pregnant, the mother's weight was low. Poor gestational weight gain, malabsorption, okay? Poor nutritional status of the mother. So the mother is not eating well. If the mother is residing at high altitudes, okay? Short inter-pregnancy intervals and extremes of maternal age, and discrepancy between crown rump length measurements and accurate menstrual history by 2 to 6 days. So these are all the things I want you to know. And what about the placental factors? What are the placental factors? If there's placental insufficiency, we said that's the most common. Velamentous cord insertion, circumvallate placenta, and single umbilical artery. These are the placental risk factors for fetal growth restriction in the baby. So before we move to the last part, somebody's asking a question. I will look at that, and maybe I'll answer that in the WhatsApp group. I think they are asking a question about Down syndrome and the lab work, whether beta HCG is low, like they are looking at the levels alpha fetoprotein and beta HCG. I will just look at that after the class and then answer that in the WhatsApp group. Okay. So, doctors, there are so many options, and I'm going to go to like the final part of the class, but there are so many options. Someone just texted me that they want to join the med drills. You can even get just 450 CAD for 1 month. It gives you access to everything in MedCognito, and you also get to attend the med drill, which is conducted during that period of your registration. You can also decide to do 420 CAD a month for 6 months as well. For those who are going for the exam in May and they just want 3 months access, we've also created something for you. Okay, just $1,350 for 3 months, and you get access. And you can also just decide to pay one time. Okay, $2,199. You get access to all med drills. You get access to, like during the 6 months period, you get access to everything on MedCognito. You get access to our inbuilt mock exams. You get access to the live class. Everything is here for you. So, doctors, if you think you are getting a lot of value from what we are doing here, can you imagine the more value you are going to get in the MedCognito program itself? Okay, so just take advantage of it and then get in touch with me at +1 306 891 5649, and let's help you to get on board and register. Okay, so now this is just a summary. Okay, today we reviewed our fetal growth restriction, where we learned that abdominal circumference and estimated fetal weight is less than the 10th percentile for gestational age, and it is pathologic. Okay, and we learned that severe fetal growth restriction is when estimated fetal weight or abdominal circumference is less than the 3rd percentile. And we also learned that early onset fetal growth restriction happens before 32 weeks. Usually it is more severe and it is often linked with placental insufficiency. We learned today that late onset fetal growth restriction is when we diagnose it after 32 weeks. That is more common, low perinatal risks, but possible neurodevelopmental impairment. We also learned that small for gestational age is usually diagnosed after birth when the birth weight is less than the 10th percentile. And it includes babies who are constitutionally small and growth restricted newborns. And we also learned today that placental insufficiency is the most common cause of fetal growth restriction. I'm just taking you through the high yield stuff we've done today. Okay, what's the best test for placental function? You want to do your umbilical artery Doppler. What's the best time for gestational age assessment? You want to do your first trimester ultrasound using the crown rump length. What about medication-associated fetal growth restriction? Think about medications like valproic acid, chemotherapy, warfarin. And what's the best management for severe fetal growth restriction with reversed end diastolic flow? You want to deliver the baby immediately because that is dangerous, right? What about fetal growth restriction and small for gestational age? We learned today that not all fetal growth restricted babies have small for gestational age, and not all small for gestational age babies had fetal growth restriction in pregnancy. Okay, and then we also learned about gestational age assessment, where we are going to use 4 things: crown rump length in the first trimester, but after the first trimester, we'll use the biparietal diameter, the head circumference, abdominal circumference, and the fetal length. And we learned that we are going to use those 4 things and use the Handlock formula, to do our estimated fetal weight. And if you want to compare standards, estimated fetal weight is compared with population-based or customized growth standards to determine percentile ranking. And umbilical artery Doppler is used to assess placental function. Abnormalities like absent or reversed end diastolic flow indicate severe fetal growth restriction. Okay? And let's look at cases and actions to take. So you have a baby with fetal growth restriction with normal Doppler, and it's like the fetal weight is more than the 10th percentile. You'd want to do your regular ultrasound monitoring every 2 to 4 weeks and do your routine antenatal care. If it is severe fetal growth restriction, you want to do close monitoring, weekly biophysical profile, and consider delivering the baby around 37 weeks. If there's fetal growth restriction with abnormal Doppler, then you want to do increased monitoring and early delivery, depending on the severity. And fetal growth restriction with reversed end diastolic flow, that's one. You want to do your immediate intervention, likely delivery at 32 to 34 weeks. So doctors, that's a wrap for today's class. I'll take my time and look into the Down syndrome concern. And then if anything, maybe I'll put a note and a comment under the video on YouTube and on Facebook as well. Okay. It's been awesome. Doctors, don't forget to get in touch with me at +1 306 891 5649. And I hope today's class has been very helpful to you and it will help you in your MCQ1 journey as you aim to ace the exam. Thank you for spending your afternoon with me. Enjoy the day with your families and your loved ones and your friends. And please don't forget to take care of yourself. Get in touch right now. +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. Thank you very much, doctors. As I said, a Down syndrome question, I'll look at it and maybe I'll put a comment in the YouTube and on Facebook as well. Thank you very much. Have a good day. Bye-bye. Bye-bye. Bye-bye.